So the next expert is Dr. Peter Parry, who has well over 3 decades, am I being controversial? 3 decades of experience in child and adolescent psychiatry, and is working in private practice at Northside Child and Youth Psychiatry. So without further ado, in Brisbane. But without further ado, please welcome Dr. Peter Parry.
So you've just heard a lot of information from my 2 colleagues, and it's probably heavy going, and there's going to be a lot more. So I suggest that everyone stands up and stretches for about 15 seconds, and then we proceed. Just by way of background, I graduated from Adelaide Medical School 40 years ago. I served as a medical officer in the Royal Australian Navy, then worked as a GP before psychiatry training from 1990, subspecialising in child and adolescent psychiatry from 1995, so it's actually just under 3 decades of child psychiatry. I have worked in community and inpatient clinics in South Australia, the UK and Queensland, and been Director of the Youth Inpatient Unit in Adelaide and Director of Mental Health Services at the Queensland Children's Hospital. I'm currently in private practice and locum work. Now, I'm going to give some wider context to the issue of gender dysphoria with a preamble about psychiatric diagnosis in general. But as a preface, I note that people with mental issues, including gender dysphoria, must be provided with empathy and strictest professional and respectful care. It also goes without saying that parents love their children, whether they are agreeing or disagreeing with the transitioning. And clinicians are all believing that they're doing the right thing for their patients, whether they are of the affirmative school or of the more traditional biopsychosocial investigative approach school. I have a PhD on the subject of a 2-decade overdiagnosis epidemic of bipolar disorder in very young children in the United States. And my thesis was titled Pediatric Bipolar Disorder, Why Did It Occur? The Iatrogenic Consequences and Implications for Psychiatric Nosology. And I'm going to explain those terms. The iatrogenic, which means harms caused by medical drugs and procedures, consequences of 25 years of over 1 million children and teens misdiagnosed and overmedicated, includes, according to a peer-reviewed publication in the official adverse event data of the FDA in the United States, is likely several thousand deaths, mostly by cardiac conduction problems from psychiatric drugs they mostly did not need. But moreover, it is parents, teachers, the children and young people themselves identifying with an illness the vast majority did not have, and therefore other causes of their emotional and behavioural problems were neglected. Nosology means the classification of diseases and diagnoses. A manual of psychiatric nosology is the DSM, the Diagnostic and Statistical Manual of Mental Disorders of the American Psychiatric Association. Now, I've taught psychiatric nosology and assessment skills to mental health workers for about 20 years, and I give a lecture tomorrow. A basic tenet of psychiatric assessment and diagnosis is to not jump to conclusions. That simply listing symptoms consistent with a diagnosis in the DSM is often not an endpoint answer, but a starting point question as to why the person is concerned is exhibiting the symptoms. Depression, as an example, can be reactive to recent bereavement, ongoing abuse, major loss, poor lifestyle, drug and alcohol use, unresolved old traumas that something triggered, or familial vulnerability to a melancholic type of depression which overlaps with the depressive phase of bipolar disorder. It is not simple. Psychiatry requires longer sessions and usually several sessions to fully assess somebody, and involves listening to family, teachers, and other relevant persons. As information is gathered, it's filtered through a grid of biological, psychological, and social factors temporally partitioned into predisposing, precipitating, perpetuating, protective, and prognostic factors. And all that information then must be synthesized in an individual, patient-centered manner for understanding their disorder or symptoms in what we in mental health call a biopsychosocial diagnostic formulation. This is standard. As an aside, because it might partly relate to the epidemic in gender dysphoria, In researching for my thesis, I encountered internal pharmaceutical industry documents released from criminal court cases involving companies like Eli Lilly, Johnson & Johnson, GSK, AstraZeneca and Pfizer. My co-researcher and I published a peer-reviewed paper in a bioethics journal titled From Evidence-Based Medicine to Marketing-Based Medicine, Evidence from Internal Industry Documents. Over 400 documents plainly indicated that companies routinely suppress adverse event data and positively spin benefits data from their clinical trials to make drugs look safer and more effective. And they also engage in something called disease mongering to expand diagnosis boundaries so as to, quote, create markets. This occurred in the overdiagnosis epidemic of childhood and even adult bipolar disorder, because the patents for most SSRI antidepressants were expiring in the early 2000s and the companies needed to make their new generation antipsychotic drugs more profitable by expanding the number of bipolar disorder diagnoses several-fold. I've also taught developmental psychology and lifestyle factors in mental health, which both require a broad evolutionary paradigm view of what it means to be human. So what has this to do with responding to Dr. Dory's invite to come from Brisbane for this evening's forum? Well, gender dysphoria, formerly gender identity disorder, is a cluster of symptoms or characteristics that has been an object of study in psychiatry and mental health fields for decades. At the individual level, someone, particularly a minor with gender dysphoria, being uncomfortable with their observable birth sex as male or female, leaving aside extremely rare cases of intersex abnormalities, needs the assistance of a thorough assessment which should take at least a few sessions and discussions with parents, and the information be filtered through the biopsychosocial intersecting with time-dependent factors grid that I've just explained for a deeper understanding of why they feel this way. And until recent times, that is what the few gender clinics for the rare gender dysphoria cases did. Often a good biopsychosocial diagnostic formulation fed back to the person in appropriate language that grants them deeper understanding of their symptoms is therapeutic in itself. It at least allows the therapeutic journey to begin. With regards to gender dysphoria, in busy child and adolescent work involving supervisory oversight of community teams, inpatient units and emergency departments since 1995, I don't recall ever seeing a single female to male gender dysphoric patient until the late 20-teens. There was less than one handful of very effeminate boys, and these boys seemed they might be more comfortable as females, but probably were on track before the last decade to being effeminate gay men and quite likely happy, particularly as modern society was becoming far less homophobic. What was strange was the inexorable rise in gender dysphoria cases since about 2017, the vast majority typically 13 to 15-year-old biological females. Or maybe I can just say 13 to 15-year-olds with two X chromosomes, not wanting to grow up into women. Sex is binary at the cellular level, which is why lifelong hormones are needed to maintain a transgender physiology. Increasingly, these young teens with two X chromosomes would describe themselves as theys, as non-binaries, though often that was a stepping stone to wanting to transition to trans males. From none in 2 decades to a trickle for 5 years and a deluge in the past 5 years. And earlier this year, when working a week's locum on a 6-bed adolescent mental health unit, there were, from memory, 7 14 to 15-year-old biologically female patients over the course of the week, of whom 5 identified as either non-binary or male. So at least in the Western world, we're dealing with a gender dysphoria epidemic. My doctoral research and my teaching the topic of nosology has made me aware of diagnostic epidemics in the mental health field. Might sound strange, but epidemics don't have to be viruses. For a quick run through of some, Coro is an anxiety syndrome where men believe their penises are retracting into their abdomens and occurs in epidemic outbreaks that can affect thousands of men in South and Southeast Asia and Africa. Mass hysteria of agitated people with anxiety-related symptoms and associated autonomic nervous system disruption based on increased focus on their bodily symptoms and a vicious cycle and seeing others with the same have occurred throughout history. The dancing manias of the Middle Ages, where often mostly young women would dance till they dropped or even died, being an archetypal example. Sometimes this manifested as contagious laughing epidemics, as infected nunneries in past centuries and Tanzanian schools in 1962, or many cases of Tourette's disorder in a New York school in 2011. In socially repressive Victorian times, hysteria was a way for mostly young women to express distress that they couldn't otherwise ventilate. Hypnosis and Freud's early career in psychoanalysis began as cures for widespread hysteria. Australia had an epidemic of RSI. Older ones remember that? Repetitive strain injury in the 1980s, with the advent of word processors and increased keyboard usage. The occasional person still gets tenosynovitis from typing, but it's no longer an epidemic threatening to bankrupt work cover. Most other countries never got the social contagion of RSI. It seems the positive reinforcement of work cover payments might have been a perpetuating factor here. I recall the satanic panic of the 1980s. It being seriously believed that numerous daycare centres in the US and then around the world were involved in satanic ritual abuse of children. Despite cases of paedophilia, as we know from the Royal Commission into Institutional Child Abuse occurring, the satanic panic was clearly gross social contagion, and childcare workers were wrongfully and traumatically indicted and jailed. The multiple personality disorder epidemic in the 1990s followed. This affected thousands of clients as therapists explored interactions with their clients' various alters, allowing for increased identification with being a multiple. When the professions realised they were perpetuating cases via affirmative treatment and precipitating the creation of new cases as the public was influenced by both the media and psychology literature, the epidemic faded. And today, genuine dissociative identity disorder cases do exist, but are once again rare. We're perhaps going through another epidemic of ADHD, where the benefits of taking psychostimulants to most people's concentration implies that large numbers of us have ADHD, but it's not that simple, and that's a discussion for another day. The autism spectrum epidemic directly relates to gender dysphoria. Diagnoses of ASD have exploded and overwhelmed the NDIS. The situation is nuanced. Cases missed in the past, now recognised, pollutants and chemicals affecting fetal and infant brain development, more premature births surviving, older parents with older sperm and eggs, changes to microbiome from glyphosate in the food chain. These are all hypothesized causes of a real increase. But there are educational and financial incentives for ASD diagnoses, and some ASD diagnoses today are just normal introverted temperaments with a bit of obsessionality and quirkiness. Where the line is drawn becomes a matter of preference rather than objective diagnostic testing. Teenage girls, as Gillian has pointed out, on the ASD spectrum, or just shy and quirky, comprise many of those presenting to gender clinics. In the 90s and early 2000s, as a child psychiatrist, these girls and some boys would present as emo. It was a big movement. Goth light, with histrionic misery replacing the histrionic aggro of the Goths. Those identifying as emo usually had some anxiety, depression, or eating disorder comorbid symptoms, and as the predisposing, precipitating, perpetuating factors for these comorbid problems were addressed by usual mental health practice, the urge to be emo often faded. How many 30 and 40-somethings remain emo today? Some in the music industry, but most have not. Now, that same demographic is presenting with gender dysphoria. But this time, a bill with almost identical wording has been introduced into many Western legislatures condemning health practitioners from exploring origins via a biopsychosocial assessment. Rather, it must be affirmation or possibly lose your license or go to jail even. We also have the first wave of detransitioners, whose stories are multiplying on social media, bitter that psychological exploration of their dysphoria was not provided, and distraught over medical sequelae that can include loss of orgasm and fertility. It seems several years before most take the difficult decision to detransition. Hormones cost over $1 million for life, let alone costs of surgery. And, analogous to the bipolar disorder false diagnosis epidemic fueled by millions in big pharma marketing, research grants and sponsored patient advocacy groups, the transactivist movement, according to the research of a Professor Jennifer Bilek, it's her research, I'm just putting it out there, receives hundreds of millions of coordinated financing from billionaires invested in the health industry, some wealthy transhumanists who wish to divorce our culture from its biological basis, and a billionaire trans woman philanthropist who's funding trans rights activism. And if this is as true as Professor Bilek's indicating, given such funding and international coordination, the sudden rise of gender dysphoria is not simply a grassroots phenomenon. Now look, it is true that feminine and masculine traits vary across the spectrum, and effeminate boys and tomboy girls always existed. Many grew up to be gay and lesbian, which thankfully it is easier to do today. But now this other option is available. So there's some fertile ground for that influence to work upon, just as there was with emotional dysregulation and tantrum behaviour for the money fueling the childhood bipolar epidemic. I have 4 anecdotes to finish with. Firstly, I and another child psychiatrist presented with the AMA state president to a Queensland parliamentary committee about a law change in January 2020 that would have criminalised a non-affirmative approach with an 18-month jail term. I argued that 2 14-year-old girls, I presented this to the committee, come into my clinic, not at the same time, but one after another, and each says the same thing. They're morbidly obese and want anorectic drugs followed by gastric sleeve surgery. The first chews candy, has a BMI of 41 and early type 2 diabetes just by their young age. I refer her to an obesity clinic where some of that treatment might be offered. The second is skeletal and about to die of starvation, so I admit her to hospital for forced refeeding under the Mental Health Act for anorexia nervosa. I went on to say, yet your bill in Parliament doesn't want me to make similar assessments of underlying causes for gender dysphoric teens. Now, the responses from the half-dozen MPs suggest they hadn't quite thought of it like that, but they got the message. In the couple of weeks after our submission, 10 of my child psychiatrist colleagues in Queensland went out of their way to contact and thank me, some saying they were glad that a couple of us had the courage to speak up. We got an amendment to the bill that allows health practitioners to inquire of gender dysphoric children according to each profession's guidelines. And as a psychiatrist, I can therefore in private practice do that, but the psychologists in adjacent rooms to me need to be more careful as their society's guidelines chime with the affirmative model. So what care a young person gets in our private clinic is different depending on which door they walk through. Second, I saw a mother with her anxiety-suffering biological daughter who was identifying as male and attending the gender clinic. The mother was trying hard to use the preferred male name and pronouns and convey that she was fully accepting of her now transitioning son. However, questioning revealed intergenerational domestic violence in a misogynistic patriarchal family culture and several male relatives incarcerated, including for murder. The mother had in fact fled with her 2 daughters and some of her sons to our region. Speaking with Mother alone, she said her sons were abusive to her, typical of the social modelling they'd grown up with. Realising she could express her feelings, she became teary and said, and to quote her because it really stuck in my mind, "I used to have my 2 girls who I could relate to as a woman. I've lost the older one who is now a son but has become aggressive like all the males in our family. And now I'm going to lose my last remaining daughter." And she cried. There's much to unpack in that case, but the obvious is why would you want to grow up to be a woman and victim of a domestically violent family culture? Third, quite a few of the female-to-male gender dysphoria cases have child sexual abuse histories. The generally accepted ballpark incidence of child sexual abuse is around 10%, higher in females and even higher in those with gender dysphoria. Abuse is often not disclosed until later in therapy. It is clear with some of these girls that becoming a feminine woman risks attracting males and re-traumatization. Becoming non-binary or trans male may subconsciously appeal as a way to avoid this. Others might tend towards promiscuity if gaining attention or affection has been sexualized. It is individual for every survivor, and of course others find ways to overcome. Fourth, final anecdote. I saw a very effeminate, genetically male teenager who from a young age had preferred girly toys, etc., and seemed quite happy transitioning. This seemed typical of the traditional rare cases of gender dysphoria prior to the current trend. And probably, if one thinks about it, the case of some cultures that the Far and Samoan culture, ladyboys and Thai culture, there's always been this male to female wanting to cross-dress, etc., and live gay lifestyles. And one dearly hopes any future surgery goes well. However, possible medical or surgical complications and hormones for life do make one wonder whether an effeminate gay cross-dressing lifestyle like the Far might suffice. Several male to female, back to male detransitioners describing loss of capacity for orgasm and other medical complications articulate that very sentiment. As these detransitioners indicate, and we'll hear from some tonight, we cannot escape biology. In terms of our biological-driven psychology, we are an animal species, like any other, that responds to positive reinforcement cues, especially to be in harmony with herd or tribe and the group narrative. One of those reinforcers is the reported millions of dollars flowing from the billionaires and transhumanist movement, Professor Bialik notes. Another is the social media, likes and shares that feed social contagion. Another is the new educational curricula. And another is the gender affirmative care model that could well be retitled the positive reinforcement model of care. And it generally eschews questioning for origins of symptoms in the way we would professionally practice for any other psychiatric disorder. Prior to the affirmative model, Professor Zucker, Canadian, who was the DSM chair of the Diagnostic Committee for Gender Identity Disorder, cited a desistance rate of 88% and a persistence to transgender rate of 12%, with what at the time was a small fraction of today's referral numbers. So, in the past, after compassionate exploration and watchful waiting, a minority of young people did indeed transition, more male to female, but the occasional female to male. And they, and all genuine cases today, including ones that wouldn't have come forward in the past, do need to be honoured and transgender care provided. However, the current positive reinforcement coming from everywhere provides parallels, as I see it, to 1990s multiple personality disorder or diagnosing thousands of preschoolers with bipolar disorder in the US, which was something that Professor Parry, the editor of the Canadian Journal of Psychiatry, said would one day be seen as, quote, the greatest scandal to befall psychiatry, end quote. Whether the current affirmative care model is also later seen as a scandal, we shall find out in the coming years. But it's good to start talking about it, and thank you.